Yes, sir, we are good to go.
Thank you. Hello, and a very good evening to all. I, Dr. Dhammadip Dabade, I welcome you all on the occasion of No Thrombosis Live Inbox. No Thrombosis Live Inbox is the unique scientific initiative wherein we learn and understand about various interventional cardiological cases. And for that, we have experts with us today. It's my privilege and honor to welcome and introduce course director for this webinar, Dr. M.S. Hiremat sir. Sir is the director at Cath Lab, Ruby Hall, Pune, President CSI 2017, Program Chair CSI Conference 2016, Convener for National Interventional Council of India CSI 2004 to 6, proctored many interventional cardiologists and has given live courses across the globe. Great experience in peripheral angioplasty, including legs, iliac, and carotid. Participated in some groundbreaking clinical trials. It's my privilege and honor to welcome and introduce moderator for this webinar, Dr. A. Srinivas Kumar sir. Sir, being the senior consultant cardiologist, director cardiology and clinical research, Apollo Hospitals, Jubilee Hills, Hyderabad. Sir is the founder, director and CEO of the FACTS Foundation, faculty at various national and international conferences, has numerous articles and publications in national and international journals, scientific advisory member for the Indian Heart Journal, reviewer for International Journal Catheterization and Cardiovascular Diagnosis, principal and co-investigator for over 10 clinical trials. Welcome, sir. It's my privilege and honor to welcome and introduce moderator for this webinar, Dr. Ramesh Natarajan, sir. Sir is the director, senior consultant, interventional cardiologist, and academic coordinator, Department of Cardiology at Kerala Institute of Medical Sciences, Trivandrum. Sir is the faculty for DNB and DM cardiology and actively involved in teaching and training. Member of various cardiology organizations, active member of Society for Continuing Medical Education and Research at the academic wing of the KIMS, faculty of several national and international conferences, and faculty in National International Council meeting held at New Delhi in 2017. Welcome, sir. It's my privilege and honor to welcome and introduce speaker for today's webinar, Dr. Himanshu Gupta. He is the consultant interventional cardiologist currently affiliated with the Department of Cardiology, Medanta Heart Institute, Medanta Hospital, Lucknow. Welcome, sir. Our second speaker, Dr. Shafiq Rahman, consultant interventional cardiologist, PN Renai Medicity, Kochi. And this is the brief agenda. We'll be having the opening remarks from our moderator, Dr. A. Srinivas Kumar sir, and we will start with the case presentation and we will go for the case discussion. With that note, I would like to stop here and I once again welcome all the delegates and the faculty members for this meeting. Over to Dr. A. Srinivas Kumar sir for the quick opening remarks for this webinar.
Thank you, Dr. Ramdeep. Actually, good evening to all the doctors. I think Dr. Shafiq also joined, it looks. Good evening to all and my co-moderator, Dr. Ramesh Natarajan sir. This No Thrombosis program is a passionate program for Dr. M.S. Hiremat sir, which has been going on since last year or so. And we discuss very interesting clinical scenarios and evoke questions and participation from the attendees too. And we all would like to have a free flow of discussion even during the case presentation, and hope we will have some good, interesting discussion too. And we have two young dynamic cardiologists wanting to present their experiences of CTO case and other interesting cases too. With this few words, I request my co-moderator Ramesh sir to say a few words if at all he wants, or we go directly go for cases. Over to you, Dr. Ramesh.
Thank you, Dr. Srinivas, and thank you, Dr. Damdeep. This is it's my first program in this series, and so of course I've been listening to Dr. Srinivas as well as Dr. Hirebat on several meetings, but we have not met in this platform. So without any further delay, we'll start off with the cases.
I request Dr. Himanshu to share the screen to start with the presentation.
Yeah, please allow me to share my screen. Yes.
Yeah.
I think it's visible.
Yes, yes, go ahead.
Yeah. So very good evening, Srinivas sir, Natarajan sir, and Hirmat sir. Thank you very much for providing this opportunity to me. I'm presenting this case I did recently. This is a 56-year-old female having chronic stable angina from last 3 months, had recent NSTMI, and she was operated for CA cervix and had the chemo radiation in 2001. She had recurrent hematuria and AKI secondary to the UTI. Among the comorbidities, she is having the hypertension, no diabetes. Echo shows fairly normal ejection fraction. ECG shows the T-wave inversions in V1 to V6 and sinus rhythm. We did the angiography, and that shows short left main and near separate origin of the LED and circumflex with dominance left system. LED is proximally severely calcified, followed by mid short segment CTO at the origin of the D1. You can see here the near separate origin of LED and circumflex, and there is a very short segment of the CTO, that is LED is filling anterogadraly with the homocollaterals. So we started with Fielder XT-A wire in the LED. We tried probing it, but every time we are pushing the wire, it is LED, the guide is unhooking. So we took the support by putting the cyan blue wire in the circumflex. Then we put the same cyan blue wire in the D1 for the better support. Crossed the short segment CTO with the help of the same Fielder XT-A wire. But after crossing the wire, our microcatheter is not crossing. So we did the pre-dilatation with 1.2 12 mm and 2 by 12 mm balloon. We again tried the microcatheter, and the microcatheter successfully crossed. Exchanged with the cyan blue wire. Did the LED stenting with 2.5 by 18 mm stent. Wires recrossed. Then the D1 is pre-dilated with 2 by 12 mm balloon. D1 is stented. And this was the result after the stenting. And FKBI done using the 212 in LED and 2.5 12 mm balloon in D1. After the angioplasty, you can see at the distal end of the LED, there's a spasm or suspected disease. We don't know what is that. It may be the residual disease, maybe thrombus or the spasm. So we took a short IVAS run to look what is there at the distal LED stent edge. So it was only the spasm. And when we took the whole LED IVAS run, we found out that the LED stent was very well opposed. There was heavy calcium at the proximal LED, but MLA was more than 4.5. So we left it like that. So learning points here is attempting CTO with bifurcation always challenging, and live cine is extremely helpful for appropriate stent replacements, and imaging guidance is utmost important to rule out the complications. Thanks a lot.
Thank you, Dr. Himanshu, for showing a good, interesting case. But you think when 3 months history only, no? You're saying so? Just recent occlusion, you feel? NST elevation MI, generally it happens with subtotal occlusions or critical LED occlusion. So probably it was just recent. That's why you could cross with a softer wire relatively, not a stiffer wire. Many of the times those CTOs, many of the times we end up crossing with fielder type of wires. That means there's a faint antigrade trickle there.
Yes.
After the wire went in, it looked unusual to me that the microcatheter couldn't go. Maybe it is a G microcatheter or N microcatheter, because sometimes we tend to use a little gassed ones that could create trouble. Because when the microcatheter doesn't go and the 2 mm balloon going is little unusual. There should be some problem in handling the microcatheter. I don't know. I'm just
maybe, sir. We are not that
because balloon 2 mm balloon went and then microcatheter didn't go. It is unusual. But you try to. That's a good policy to exchange that field XT wire once the purpose of crossing is done. Because otherwise, sometimes that wire could keep on. If you're not doing it, you have not changed it. One assistant should keep holding that wire so that wire doesn't seek distally. Otherwise, it tends to go distally and tends to cause perforations too. So that is why it's very important to handle the thing. And once the job of crossing is done, then probably if you have a microcatheter, you thought of exchanging to regular workhorse wire. That's a good practice to do. Here you couldn't do it maybe because of the microcatheter didn't go, but balloon went and they did dilatation. So one more important thing is before you do it, you decide on what type of bifurcation technique you are following also. So probably you thought minimal protrusion tap-like thing is okay, because most of the times if the vessels are not very big, only left main, we tend to do DK crush and things like that. Here it was distally occluded. That's why I think this is reasonable method to do LED diagonal thing. But I thought little the stunt LED stent size was little small for the proximal bigger vessel. I think you did a part finally, the proximal thing. I didn't.
Yes, sir. It was done. It was done. I think it is not there in the images.
It is not there in the image. It didn't see it, but it is mandatory to do part in the end after kissing also. Because after doing kissing also sometimes stents get distorted. And that's how the final part is very important. And you also demonstrated it well by doing imaging. That's another good thing which helped. But distally, the LED vessel could be spasm. Initially, also you're thinking on angio also like that. I think same thing. You can confirm by ruling out any dissection. There's a possibility. But by and large, overall, I think result was quite good, and that's how patient must have done well. Thanks for showing this case. Any other comments, Dr. Ramesh, sir?
Yeah, it was a nice case. Only thing, you didn't elaborate much on the bifurcation stenting strategy. Because did you think initially itself you were planning for a 2-stent strategy? Because I thought the diagonal ostium looked okay. So I thought you would get away with a single stent. But you didn't elaborate on what stenting strategy you did, because you did a kissing balloon after stenting from the LED to the diagonal, right?
Yeah. So we did QLO this.
It's a QLOT, right?
Yeah, QLO we did. Or you can say the mini QLO.
QLOT means more protrusion should happen. It is basically a mini tap or whatever you call it. But what sir is telling is, had a diagonal was open, he would have thought about it in more detail, I think, sir. Because the LED was occluded, he didn't plan it in detail before. Once the LED was open, then his plans came. But generally, by and large, if the diagonal ostium is free from disease, so if you do a crossover type of thing also with one stent, nothing could happen to the diagonal. Though sometimes it could pinch angiographically, but overall, if you do FFRs also, people say it could come negative. Or at the most, provisional stenting. Provisional stenting actually is like a stenting of the ostium of the side branch versus the stenting of the main vessel. That's how the provisional stent works well. It is not that you're not stenting the side branch. When you do provisional stent, one of the main vessel stent comes and approximates onto the origin of the branch. That's how they do well. So you could have got away with that also, sir was telling. But he didn't think that way because I didn't see the pictures, because running pictures would tell you more rather than pictures we made like this. Suppose in pinching of the vessel of the diagonal ostium is there, where again significant pinching with decreased flow, then definitely no doubts you'll address with the stent. But if it's not much of pinching, even minimal pinching with flow adequate, nowadays you could have got away with the provisional stenting. That's what I think sir is hinting. But anyway, it was he occluded before, he didn't decide prior. I think later on, as an ad hoc measure, he thought he could do that. Other reason is the diagonal looked bigger in size to him compared to the distal vessel. That's why he didn't want to leave that diagonal maybe. But If the diagonal ostium is free from disease, you could still got away with it. But anyway, each of us learn from our experiences. But by and large, for sake of audience, when the ostium of the diagonal is not diseased, even if it is minimal diseased, it's okay. If it is not crossing the 10 mm length, or the tightness of stenosis is not significant, you may most of the time get away by doing a provisional stent. Now, one more thing, new concept which is coming up is doing a drug-eluting balloon to side branch also, just to patch it up at low pressure, so that you deliver the drug at the same time. You're not putting two layers of metals. Now, Coulard, the problem is if you put 2 layers of metals, nowadays the latest generation stents are okay because thin struts. You could get away with 2 layers also. Earlier, Coulards were not doing good results because stent struts were very thick. The latest generation results show Coulard also okay because stent struts are thinner. That's how patients do all right. But as long as clinically, wherever possible, you try to avoid too much of stent overlaps and too much of material. That's how minimal tap or just protrusion with minimal what you did is okay. You need not come too much into the main vessel like doing a full-fledged Coulard. These are my thoughts. Anything you want to say, Dr. Shafiq? You unmute yourself. You are muted. You are muted. Or Shafiq, you are muted. Unmute yourself. Yeah, now you can talk.
Yeah, unfortunately, I was just got hold of my slides. I was just looking through my slides. I couldn't attend the presentation, which was previously.
Yeah,
So
no problem. If you wanted to say something, you can. Otherwise, if you want to go to your presentation, we can.
Shall I go ahead with my presentation?
Yes.
In fact, this is a patient I had done an angioplasty 5 to 6 years back. He had his basic issue was intractable angina. He had a history of 2 angioplasties at a CABG done. The first angioplasty was done in 1991 for exertional angina and a TMT positivity, but then we didn't have the clear anatomy or the records that was done at that point of time. Afterwards, there was again an episode of unstable angina. He underwent re-CAG and underwent CABG with grafts to the left system. The right coronary artery was not grafted. Again, he had graft failure, symptomatic graft failure. And in 2002, again, an angiogram was done where the left system lima was occluded. The SVG to LAD had a mid 90% stenosis, and the SVG to OM is also occluded. So he underwent covered stent angioplasty to his SVG to LAD, and an angioplasty PTC to RC was done with a 15 mm Prolink stent. And now he has come with class 3 exertional angina. I had put him on all possible anti-anginals, antiplatelets, statins, everything was put in, but then he continued to have angina, and then we took him up to understand what the coronary anatomy was. So this was the right system. The right coronary artery, the stent appeared patent. There's no much disease which can contribute to his angina on the right side. However, the native vessels on the left side, you can see that the LAD ostium is occluded, and also the proximal circumflex has a CTO, and there is some collateral flow distally in the circumflex. So there's nothing much we could offer to do in his native vessels. And when we looked at the graft angiogram, the lima appeared stringed, and the SVG to OM was not traceable, and it is considered as occluded. So the only surviving graft was the SVG to distal LAD. This was only the surviving graft, but it was also diffusely diseased. And this graft has also failed earlier, and there was a covered stent in its mid part, which was reasonably patent with only mild ingrowth. However, if you look at the second image, you can see that the SVG ostium has mild disease, which we are not sure how much it was. And of course, the anastomotic site has a tight lesion, after which there is some 60-70% disease, followed by a distal LAD showing a CTO. That was what the anatomy was. So I sent this patient back home, and I thought I would look into this angiogram and strategize before taking up for any kind of procedure. I was pretty sure addressing his SVG lesions will definitely bring at least a reduction in the number of medications that will be used for controlling his angina. So I will summarize my case here. He's a 56-year-old young gentleman, middle-aged gentleman who was quite active. He has all comorbidities, diabetes, hypertension, dyslipidemia, and CAD with significant ischemic burden requiring multiple anti-anginal medications. Despite that, having class 3 exertional angina, he's had 2 angioplasties, bypass surgery, and now also a post-graft angioplasty, and now he has his current lesions we are planning to assess, planning to solve are 2 new lesions in a degenerated 22-year-old graft. And also the native distal LAD also has 70% disease followed by a CTO. So this was how I planned. I thought the native distal RC and OM disease are not that significant. We'll put them on medical management. Tackle the distal anastomotic SVG lesion with an angioplasty, and then reassess the SVG ostium to see whether that needs to be opened up, and also to do PTC of mid LAD and distal CTO through the graft, and use a distal protection device for the SVG intervention. So the plan was to handle the distal LAD properly and put in a distal protection device and then handle the venous graft. So these were the challenges I was considering at that point of time. This is a 22-year-old degenerated graft. There is no landing zone for distal protection devices. So I had to fix the native distal LAD first to create a landing zone, and then put in a distal protection device before going and handling the venous graft. And clearly, in such a scenario, the chances of a no reflow is high, especially with so much of hardware going into that area. And whether should I go for a radial versus transfemoral approach? But being mostly trained in a radial situation, a radial environment, so my first thoughts was, let us go radial. I might get away with it. So this was what was attempted first. A right radial access, 6 French, and non-hydrophilic wire was used to cross. The wire did cross, and with the help of a buddy. So I think it's coming in the next picture. I used a BMW buddy wire and a fielder XT to cross the lesions. I could manage to cross the lesions. Hope the videos are visible. After which the anastomotic site was dilated with a 1.5 balloon. Then I started falling into trouble. The CTOs also, we were able to cross the CTO with a 1.5 balloon, but a larger balloon was not passing through the CTO, and there was not much support being provided by the radial guide. And it was keeping on backing up, and then I was not able to continue with the procedure. And hence, the distal lesion appeared okay. There's no major dissection, but then because of the poor support, I decided to go for a different approach. I did try the radial approach again, but with different guides, but then finally decided to go the femoral way. So when we in the transfemoral way with a 6 French GR4 guide, fielder wire was used, and after that the distal CTO could be opened with a larger balloon. I used a 2x12 balloon, which crossed a little bit more easily. And once I did that, I also dilated the anastomotic site with a larger balloon, a 2.75 NC balloon. And now I was implanted a stent at the distal LAD. A 2.5 into 24 millimeter drug-eluting stent was done, and post-dilated to the 2.5 NC. So this was what the distal LAD. I thought maybe, okay, now this is a much open place, and then I introduced the distal protection devices. I chose Abbott's EmboShield NAV6 device and deployed the NAV6 distally, and then proceeded to do an angioplasty of SVG to LAD with the drug-eluting stent at 2.75 into 21 millimeter across the anastomotic side. And the stent was optimized with a 2.75 NC. I reassessed the ostium of the SVG. It looked more significant with the guide catheters, and then proceeded to predilate the SVG ostium with a 3 NC balloon, and then implanted a 4 into 18 millimeter drug-eluting stent there. And this was optimized with a 4x12 NC balloon. And once I was sure that there was a reasonable flow achieved, decided to retrieve the NAV6. And this is the final result I obtained. And TME3 flow was achieved. And the patient did symptomatically much better. He's still on follow-up. He has 2 anti-anginals now, but quite active. He's around 60, 62 around now, but then he's a quite active person. He's still under follow-up. So these are my final thoughts on this case. This is a femoral access should have been the choice in the beginning itself. Used a femoral access with the fielder extra wire, NC balloons. 3 regulating stents were used. NAV6 digital protection device was used. This was my initial follow-up at 8 months. He had no, even now he's on follow-up with good symptomatic relief, and his LV function has always been normal. So these are the points I thought should be, I pondered during that time. However, the complex the problem may seem, in fact, I sent this patient back. There was no urgency to do an angioplasty on the same day. So I sat down for 1 or 2 days, strategized, and then decided how to go. So the right access, the optimum guides to be used, how the wiring strategy should be all thought of beforehand. And there is no question about the use of digital protection devices in old degenerated grafts. This should be done, and always have a plan B or C ready when you need to change hardware strategy. So these are the exactly. That's the end of my case. Thank you.
Can you show native picture once, native shots once, Dr. Shafiq?
I show you native shots. Lady ostium was occluded, and LCX proximally there was a CTO. There's some collateral filling in the circumflex area, while a lady I think was only getting filled with that venous graft.
See, that's why I keep telling. Once the patient goes for surgery, entire arterial tree gets mucked up. See the way how the arteries degenerate. Surgeons claim that they take care of entire disease. It's actually, I feel it is the reverse. That's why what I keep telling you, I think you can close the slides. RCA was also occluded, I think, no? Right one?
RCA was patent. He has underwent an angioplasty to RCA. It was never grafted. RCA was not.
So it was functioning all right, RCA?
RCA is functioning. There is some
patent.
Okay. Some retrograde filling was seen towards that side, from left side. So small distal branch, I think. That's fine. So basically, what I would like to say is, I keep telling this, keep repeating it again and again. In today's era, patient is now 52 years. So 20 years old, 22-year-old degenerative graft, you said. And that means patient was sent for surgery around 35 years of age. Roughly?
Absolutely, absolutely. That's right.
35 years of age, no surgery first. Let me tell you. Whatever, unless you're forced to send patients for surgery because of some exceptionally bad disease or total occlusions everywhere. So that's what happens. If you send a patient of surgery at 35 years of age, he's tend to come back and so ugly disease, and already 2 times stents done, 3rd time again comes, the venous grafts again get occluded. It's a mess. So always I say, don't send any patient for surgery at such a young age. I think nowadays this is being practiced very commonly. This was very old time, the thing. That's how patients must have been sent for surgery. That's my first take on this case. Once the surgery is done, then patients' native vessels all go into mucked up vessels, and then you can't reverse. A lot of challenges happen. And as you understand, lima will be all right, SVG gets occluded. Here, I don't know why the 20 years back, limas were also not given, I think. The SVG was given to LAD. There's another worst thing which happened to patient. Unless your surgeon gives lima to LAD, don't send to such surgeons. Because
I have actually grafted with the lima to LAD, but that has been string. Probably the lima was not long enough.
So that got occluded, then they put a venous graft. So that sometimes when the table itself, when they find it some trouble to lima, they will put additional vein graft, because that sometimes some surgeons do it. That means they've already mucked up lima on table, some problems must have happened, then additional venous graft. That is again unfortunate for a young fellow. Young patient, total arterial revascularization at least is done, it would have been better. that is the prior thoughts, what has happened before to the patient. You can't help it now. That patient coming with recurrent angina now, you studied it, and probably what best you can possibly do. You did a good job. I appreciate you for that. Just only for the sake of discussion, I'm just bringing some thought process. And this, I strongly believe at 35 years, no surgery, please. And again, at 75 years of morbid age, again, no surgery, because it's not easy. Poor protoplasm friable, and patients do. Many times, surgeons also don't like to operate 75 years plus patients. So somewhere in between 60 and 75 surgery may be okay, but not before they retire, not too long after it. That's my take on surgery first. The second thing is, if after some things have degenerated, what you showed, planned the procedure and all that, you told very nicely. But many of the times you could get away even with radial. You almost did it. I feel with little more perseverance, probably even that radial, because wire went in, the Fielder XT went in, you could have little more persisted with it, you could have gone it. But anyway, but femoral, you're comfortable, I think you changed to femoral, but finally the procedure should be done right. Be not radialism, or it's not like a total radial, total femoral. What is good for the patient, we need to do it. That's what I strongly believe in it, and you did it. Sometimes taking a little bigger French catheter would also help. Radial, we were worried to take 7 French catheters before. Now you have a slender sheath with 6 and 7, you put even the 7 French guide could go through radial. So that also gives better support. Before we totally switch on to femoral, because sometimes if you don't like, again, puncturing the patient in different things. So that another could have been done for the guide access. The wire crossing, I think you had a faint track. That's how we took a Fielder XT. But sometimes, as I told in the before case, once that job is done, we could exchange with a regular workhorse wire to avoid problems. It looked like it was almost about to perforate at the distal point of that where it was tracking around. There was small pooling also was happening. Luckily, it didn't progress. So sometimes if we're not careful, that could lead to distal wire perforations. That's why we tend to take out that wire once the job is done. And then you have good tracking balloons, and it was done, opened well. But I was a little challenged about putting the venous graft. Generally, by and large, the most of the embolism happens. You did what is possible. Obviously, there's no space. There's occlusion distally. For sake of discussion, I'm getting it. So generally, once you predilate with the bigger size balloon, the tightest portion is the one which actually embolizes the material. So you did the distal thing, and you created a space and then put a filter device. But meanwhile itself also some embolism could have happened. There's no choice, but because basically in such scenarios, I think you again use a filter where you allow the native wire to be used. I think Emcure and even that what is that filter of whichever filter you're comfortable, you can use it. But the filters which have access to a native wire, over which you can exchange, like M-Shield is one, and Spider is another filter, where you can exchange your native wires with the filter wire. That sort of things may be preferable in such critical disease, I think, which you did it. And while getting the filter out also, you need to be careful sometimes. The material, if you pull the filter back, the sheet should be taken onto the filter rather than pulling the filter back. And otherwise, the entire material could embolize while taking it out. So those are some of the things, but final result in the LED looked beautiful, and that was also perfusing some portions of the OM and some portion of the distal vessel. The LED was actually wrapping around the apex, and that's how the patient should do well. But if possible, I think the native LCX also could be seen well, and if CTO, like if it is there's a possibility that could also be opening, because this was opening the proximal OM part, but distal lower OM is still occluded, though it is filling, I think, through some collaterals. So, but finally, I think you did a good job and result came out well. And proximal lesion assessment in the SVG, you said, never leave such lesions in venous grafts, because they tend to degenerate fast, and within 3 months, patients will come back. So even if it's looking a little less important, unlike the native vessel, venous graft, you're not supposed to leave. Better stent it, and otherwise the patient will come back. You did a good job distally, again, he'll come back with a proximal restenosis type progression, which will be effectively not good again. So that's a good thing you did by stenting the proximal vessel also. The point which I want to make for listeners is the SVG intervention graft disease is slightly different. You tend to approach it and treat it before, even if it is not very critical, because it tends to progress very fast. So I'm not telling you do it for 20%, 10% lesions, but if lesion is looking on the borderline side, you'd add towards treating it with stent because the disease tends to progress faster. These are some of my thoughts. Thanks for showing an excellent case. And nowadays we see it less and less common because more of these patients are tackled with stents more common. I think these are my comments. Dr. Ramesh, sir, your comment?
Excellent case, Shafiq. You did whatever possible best for the case. Just Dr. Srinivas has mentioned almost all the points. I fully agree that 35 years one should not subject the patient to a bypass surgery. And it was unfortunate that the Lima got attritic in this case. One or two points, usually it's always better, I feel, that to go femoral in dealing with the vein grafts. You get a much better support. You have a choice of guides to use. I think you use a AR or something in the beginning. I saw you that one of the pictures.
I did try.
Yeah. So you have a more selection of guides to use with that. Then another thing which I thought was, you mentioned that it's a 22-year-old degenerated graft, but the role of the distal protection device, in fact, is coming down of late. And mainly for the shaft and the body of the graft, that is where you tend to use the distal protection. But for the distal anastomotic, I would rather in this case, I would have done it without a distal protection because there's no need to place a distal protection in the native vessel distally. So whatever you're doing is to prevent embolization into the native vessel. So you keep it in the distal, the landing zone is the distal part of the body of the graft. So for more proximal and mid shaft lesions, where you tend to use this thing, because the distal anastomotic site, usually the muck or the debris are not very large, as in the middle. So that was one point which I thought. And nowadays, more and more direct stenting and doing away with the distal protection is.
How about this covered stent strategy and those Emcure?
Covered stent is now out. We're surprised to see that the covered stent is patent even after so many years, because actually the problem with the early use of covered stent in vein grafts was that restenosis used to be very high.
How about Emcure stent used to be available, sir, earlier?
Yeah, Emcure is not there now. Emcure is not being used now. But it was that was mainly for the native.
It was a bare metal stent. It is given up because of high risk. And I couldn't say it better because you did it with so much passion. I didn't directly tell filter was not used because you used so much attempts to place the filter. But I did mention softly.
Intractable angina. This is the only vessel I have.
After doing angioplasty there, putting a stent there, still you took a filter there. So that's what I did want to dishearten you. But I think sir told it clearly because it's so much after work. You're doing so much work generally. You may not get so much of benefit. But anyway, by and large, I think degenerated venous graft. Yeah, I think by and large, with degenerated venous graft, you tend to use filter. That's the only place where the people use filter. But in this case, as sir mentioned, maybe benefit is not much. In that process, if you produce trouble, then you will feel more bad about it. Luckily, with good intention you do, God also cooperates. I think everything went well. I think good case. Himanshu, any thoughts of you want to say anything about that case?
Nothing, sir. Dr. Shafiq, it was an excellent case. Only I want to think that when the SPECT or the stress thallium can be done to look out all the ischemic areas. And second thing is that what the Natarajan sir told, like I did about 2 to 3 cases of plasty to the anastomotic site. But we usually, although those cases are within 5 years of the post bypass, but we never used distal protection devices. I think all of them I got good results.
Your point of getting a thallium done, stress scan done, is generally his patient is getting recurrent angina. He has a critical disease. Yeah. That's why I think he didn't think of doing a scan. And once you have a critical lesion somewhere, it automatically manifests with angina, and you may not pick up the other lesion vessels also. Now you can do if you want to assess the residual ischemia in OM territory, because the RCA is open, now LAD is open. You want to decide whether OM has to be tackled or not, you can do a ischemia study now. Not when the patient has angina and a critical stenosis. That itself shows that something is wrong and you have to tackle it. So, but oral assessment wise, you must have told that. But generally, by the time it becomes one area becomes ischemic, other areas may not show up much. That's how I think earlier scan is not required. Now, if you want to tackle OM, you can plan ischemia study. Your other point other thing what you mentioned was regarding the anastomotic site stenosis. Anastomotic site stenosis, by and large, is the high chance, could be little more tough to deal with because of mismatch between the distal vessel and the proximal graft, whether it be venous graft or lima. Sometimes we tend to slightly take a in-between size stent and put it and post-dilate it without going too much into the distal vessel to avoid the problem. So I agreed. Your point is patients of anastomotic site need to be tackled slightly different compared to native, like in the graft where you have a shaft disease, where there you can be a little aggressive, take a bigger size. But for the sake of listeners, again, though it looks like a little smaller size because of thrombosis or anything, never take less than 3.5 sized stent for the venous graft, because generally if you take a thinner, thinking that it is smaller size to take a 2.75 stent or something, it will embolize. So it will move the place. Always keep that in mind. And again, take a little optimal size stent and don't go to too much high pressures. That will again could cause to more of slow flow like things. So take optimal size stent and go up to nominal and come out if possible, unless there is a very degenerate. That's how you tend to prepare it also prior if you suspect very tough lesions. Those are some of the points regarding the graft and the anastomotic site lesions. But by and large, God is great. You think that it causes such a critical disease, anastomotic, how the patient behaves, but still patients do all right. Because very critical stenosis, once it's opened, a lot of ischemia gets relieved and patients do all right. I think that's how you got a good results. I think good comments, good cases. Anything else we have to discuss, or should we close? I think Hiramatsa didn't join. If there are any comments further, we could take. Otherwise, we can close.
I think if he comes back with angina, Shafiq, you should try the CTO of the circumference.
Okay. Sir, how's your, you feel that is an openable CTO?
No, we couldn't see it well actually. If you take a good picture with the guide catheter and see whether the faint trickle or water, still I think it's a big sized LCX. It's not a very thin LCX. Okay. And left main, and it is like a protected left main now.
I think it's a protected.
Once the lima is done now, already is taken care. If you tackle it, if it opens, it opens. Otherwise, nothing going. Not going to do it.
Nothing more can be offered if it comes to the angina.
Yeah, but if he has angina, as sir said, you can assess that, and we could try to open that also if possible. Okay. I think good cases. One was an acute scenario, other was in a chronic scenario, and one how we get day-to-day routine mundane type case. But again, interesting aspect was it as a bifurcation. We did discuss provisional stenting could have been done there, but Minitab also worked, and probably use of imaging to rule out confirm only spasm, no dissection. And again, the proximal part, everything was shown well in the first case highlighted. The second case, what we showed, again, a very chronic disease, which you see less commonly, but very well tackled with venous graft intervention. And we had very good discussion, I think, with good cases. Thank you. Over to you, Dr. Damdeep.
Yeah, thank you, sir, for nicely concluding and coming with your remarks for both the cases. I'm really thankful for you and Dr. Ramesh Natarajan, sir, for nicely directing and discussing about both these cases. I am thankful for our speaker, Dr. Himanshu Gupta, sir, and also Dr. Shafiq Rahman, sir, to actually bringing those two cases. And I hope with that, all the delegates who were listening to us must have been benefited and may help during their further practices. Then with the hope, I'm looking forward to meet you all in the next meeting and to come up with another set of the interesting cases. So with that note, again, I'm thankful to all of you, all the delegates and the faculty members. Very good evening and good time ahead. Thank you.
Thank you.
Thank you.